My name is Jacob Mark. I'm a faculty member at the Digestive Health Institute at Children's Hospital Colorado and the University of Colorado School of Medicine. I performed the study with the guidance of my mentor, Robert Kramer. Our study is entitled Impact of Fellow Training Level on Adverse Events and Operative Time for Common Pediatric Gastrointestinal Endoscopic Procedures. Our study started from the clinical question, is the current training system for pediatric endoscopies safe for the patients? This is a very important question for physicians and patient families. Families and children have asked me the same question, but phrase it as, how many of these have you done? Or they may ask that trainees not be involved in their child's endoscopy. These questions and requests speak to the question that all providers should ask before any procedure. That is what what we are about to do going to place the patient at any more risk than is absolutely necessary? There are mixed results in pediatric and adult studies on the safety of endoscopic training, which we have referenced in our article. However, there are some aspects to this question which have not been assessed well previously. Most studies in pediatrics have retrospectively reviewed adverse event rates identified in the perioperative time period, which may underestimate adverse events, especially those with delayed presentations. No studies in the pediatric population have examined the training level of a fellow and the effects that this may have on the rates of adverse events. This is an important consideration because a fellow on day one of fellowship has a very different skill level than that same fellow on the last day of fellowship. The second part of this study examined a different feature of the potential impact of trainees on pediatric endoscopy. There is concern that prolonged or repeated exposures to anesthesia in children may have long-term permanent effects on neurocognitive development. We examined operative times of common endoscopic procedures with fellows present at different levels of training and compared those to endoscopies performed by attendings alone. We expected that procedures with fellows, especially early in training, would take longer than procedures done by attendings alone, but the time difference has never been quantified in pediatrics. The goal was to determine the time differences and assess if they are likely to have neurocognitive effects on the child based on current literature on the subject. What made this study possible and significantly adds to the strength of the findings is that at Children's Hospital Colorado, we have implemented a prospective adverse event tracking and severity scoring system for endoscopies. After a child undergoes an endoscopic procedure, they are monitored for 72 hours for potential adverse events. We use several methods, which are described in detail in the manuscript, to capture possible adverse events. Any possible adverse event is reviewed by a director of endoscopy to determine if it could be reasonably attributed to the procedure. If, after review, there is an adverse event related to the endoscopy, the severity is scored using a 5-point system which we describe in the manuscript. This monitoring system had tracked 7 years of data by the time of the study, which allowed us to analyze 15,886 procedures from 19 different pediatric attending gastroenterologists and 21 fellows. We found 413 total adverse events, which is a rate of 2.6%. 200 of these were minor grade 1 adverse events managed at home. There's a much more detailed analysis of the data in the manuscript. Overall, we found that rates of adverse events vary depending on the type of procedure, with therapeutic procedures carrying higher risks of adverse events. The presence of a fellow was not associated with increased rates of adverse events of any severity, regardless of the training level of the fellow or the type of endoscopic procedure. For the operative time analysis, we examined the two most commonly performed endoscopic procedures in pediatrics, upper endoscopy alone and colonoscopy with upper endoscopy. We analyzed operative times for 3,746 upper endoscopies alone and 1,291 upper endoscopies with colonoscopies. Median operative times for upper endoscopies were 17 versus 9 minutes, which is 88% longer, with a fellow in the first quarter of their first year of training compared to those with attendings alone. Operative times decreased during the first year of training, then remained at 11 minutes for second and third year fellows. Upper endoscopy with colonoscopy times were 55 versus 37 minutes, or 49% longer for fellows in the first half of their first year compared with attendings alone. Efficiency improved during training, but second and third year fellows still required 47 minutes, which was 27% longer than attendings. In conclusion, we found that the current pediatric endoscopic training practices at our institution are safe for the patients both for diagnostic and therapeutic procedures. We demonstrated, as expected, that procedures take longer with trainees present, and this difference is the largest early in training. From what is currently known about neurocognitive risks of anesthesia exposure, the amount of increased time required for trainees is unlikely to have any long-term neurocognitive effects for the child. There are several limitations to this study. First, this is a single-center study. Training practices may differ between institutions. Second, we could not assess the degree of fellow involvement during the procedure. If there was a perforation from a polypectomy, we could not determine if it was the attending or the fellow who was holding the endoscope when the perforation occurred. Third, there was no controlling for potential differences in patient populations for patients who underwent endoscopies with a fellow versus those who underwent endoscopies without a fellow. One way to address these limitations would be to perform a prospective multicenter study. However, given the overall relatively low rates of endoscopic adverse events in pediatrics, it would be very difficult to prospectively enroll a sufficiently large enough number of children undergoing procedures to adequately address the question. An alternative would be for institutions to adopt prospective adverse event monitoring systems and begin analyzing endoscopic adverse events at their institution. If they find that fellows are associated with adverse events at their institution, it would prompt evaluation of their training practices. Thank you for your attention, and we hope you find our manuscript beneficial.